Dr. L.H. Hiranandani Hospital is the jewel in the medical crown of Mumbai. In the year 2006, the hospital was able to get the ISO 9001-2008 certification. Our hospital was chosen the winner of the Ramakrishna Bajaj National Quality Award for Healthcare. We also competed at the Asia Pacific Awards for the best hospital in the region, and we were declared the winners. As a multi-speciality tertiary and quaternary care hospital, we are proud to identify ourselves as a frontline provider for comprehensive healthcare. We are enjoined in our journey to perfection. While it may take a while to get there, we will surely meet excellence a lot earlier.
Hello.
Hello.
Hello. Can you hear us?
Yes, we can hear you.
Yeah.
Can
Hello.
you hear us?
Yes, we can hear you. Hello.
Okay.
This is Paul Ong. We are now live from Sing Live. I'm the co-chair together with Dr. Khan, and we have a big panelist here. So perhaps we can ask you to introduce the case to us.
Yes, so I'm Dr. Ganesh Kumar, and with me is Dr. Irfan Khan. Thank you for having us with Sing Live.
Hello.
Can you hear me?
We can hear you very well.
Okay.
Welcome to Sing Live.
Thank you very much. Good evening, Dr. Ong, Dr. Khan, and the distinguished panelists. With me is Dr. Irfan Khan, Dr. Rishikesh Patil, they are my colleague cardiologists. Shefali is the nurse who is at the foot end, and Digambar is the technician. And we have anesthetist team supporting from behind. Now, Dr. Irfan, can you present the case for today? I have been told by the Sing Live to show a case of small vessel disease. We have in plenty, so we selected one, so let's have the presentation.
Good afternoon. Good afternoon, everybody here there in Singapore. Basically, the case involves a 55-year-old male. He is a tobacco addict. History of chest pain was there 2 months back. Diagnosed as acute anterior wall MI. He was thrombolized with Elaxin. And once he recovered from it, patient underwent a coronary angiogram at a local hospital. Post coronary angiogram, he had acute kidney injury, from which he recovered completely. We have done his investigations. At present his hemoglobin is 11.2 grams percent. His GFR is around, creatinine clearance is around 55 ml per minute. ECG is normal sinus rhythm. There are T-wave inversions in anterior leads. And on the echo, you have regional wall motion abnormality in the anterolateral segments at mid and distal level with preserved thickness. Ejection fraction is around 40-45% or so. There is no significant pulmonary hypertension. At present, the medication includes the antiplatelets, that is the dual antiplatelets, statins, nitrates, and beta blockers. Since he had an history of an acute kidney injury, we have already started him on IV hydration with normal saline at the rate of 50 ml per hour since the last 24 hours.
Okay, so this is the angiogram which we did today. We took very limited pictures because of the previous history of acute kidney injury. So go back. So there is a long segment CTO in the mid circumflex. The left main looks normal. The LED proximal seems an ectatic vessel is giving a diagonal.
Yeah, we can see that.
With some disease in the mid diagonal. There's a critical lesion in the mid LED, and the entire LED seems to be diffusely diseased on an angiogram. That can't be the size of his LED. Next picture. We just took limited pictures, and there is another high-grade stenosis in the distal. There is early bifurcation, so I will call this as PLV, and it's fairly big in terms of the length of the artery. So we thought this is an appropriate case for today's discussion. Small vessel at the same time supplying significant myocardium. Next. Okay, wait. So this is what we have.
Yeah, Dr. Kumar.
Yes.
I'm Dr. Khan. Yes, it's a triple vessel disease, and the patient so far, what I've heard, that the patient is not diabetic, right?
Yeah.
Patient is not
and
diabetic.
Only 55 years.
Yes,
but
55
still
years.
So small vessel.
Yes. So we believe we will image him eventually.
It's quite strange that he has a very diffuse small vessel disease.
Yes. So
Okay, we see the angiogram, and maybe we will just give us a bit of time, and maybe we can just ask our panelists what their view is. We know this is an anterior infarct that has been thrombolized, right? So, Aaron, can I, ask you to just, share with us what your strategy and plan will be for this patient, young patients?
Yeah, I think the culprit is probably the LAD. So I'll probably, they've got triple vessel disease, so I'll probably treat the LAD first. And I would, if it's easy to treat, then I might go for try to attempt a CTO. But how to treat the LAD, because it's very diffusely diseased. So I probably just treat the tightest area. The rest, I probably just leave it alone.
Yeah. And of course, this issue of possibly contrast-induced nephropathy last time after diagnostic, the contrast will be the issue. Ashley from Malaysia, any comment?
Hi, I think it's triple vessel. Only thing is most of the disease are distal, Even for the surgeon to do, they will say your targets might not be so great and so on, and the PLV and so on. But I agree with Aaron that the LAD is the culprit and it looks tight. To treat that spot, I might use imaging to reduce the usage of contrast.
Can we see the LAD again?
go back to LAD.
While we're waiting, is it possible for us to see the LAD picture again? I presume, yeah. And Donnie, any comment?
Yes, look like surely it's triple vessel disease. If you calculate the syntax score, is of course the highest syntax score. But I see also the big diagonal there. So I know this kind of debate. So I think I think the surgery is also an option of this kind of patient, because you don't want to lose or avoid the diagonal one. But of course there is some chance that they will be ended with the atractomy and LAD, which is not good in the surgery. But if you want to go to PCI, of course the LAD will be our target vessel.
So,
Okay.
Dr. Kumar, maybe you can share with us what your plan and strategy it is for this very interesting case.
So we thought before we go in live, we will just treat his PLV and then come back to the LAD, just for the convenience of the live case. I've done that. Perhaps yes, even I would have gone with the LAD first. Though the PLV looks there is TB3 flow, but the lesion looks quite nasty, and we took a 6 French guiding JR, next picture, and we were getting a lot of damping of pressure there, and my wire I couldn't advance further. This was a Xion blue wire, so we had to change it to a side hole JR, next, and again tried with a Xion blue with the help of fielders, with the help of
XT.
come again.
Fielder XT.
Now we had to switch over to Fielder XT over fine cross, and then only we could advance our wire. So because of the bend and some calcium, I'm not sure whether you're able to appreciate at the level of lesion, and there is a bend and some calcium there. So we had to struggle, and we couldn't advance our fine cross, and our guide support is not so good. Maybe retrospectively I could have gone with an AL1 with a side hole. Anyway, we pulled out our fine cross and went with a 1.0 CTO balloon, and we could advance it some distance, and eventually on third or fourth attempt we could do it. Our guide would back. Unfortunately, the guide support was not good. Then we escalated to a 1.5 balloon, and then we moved back to Xion blue over fine cross, and this is where we are. This is the picture we got. So we thought we'll take an advantage of showing you two small vessel disease treatment, and perhaps we may not be able to graduate to a CTO in the given hour, but if we use a lesser contrast, maybe we will do the CTO. But looking at the contrast induced nephropathy, maybe we will stage the CTO at a later date. So this is where we are now. So my colleague,
So I just for the audience, the patient presented with anterior infarct.
That was more than
but
2
you
months
decided
back.
to do the RCA first. Is that what's the law? Yeah.
the logic is two. One is it's 2 months old infarction. The patient is quite stable now. Okay, and his EF is,
I see.
yeah, so we thought we will just treat the right coronary, and also convenience sake, I wanted to go live for the LAD by the time I'm already live. We had to do an emergency case just half an hour back, so I thought I will finish the right coronary and then come to the LAD by the time I'm live, to be honest.
Okay.
Yeah.
Please go ahead and do it.
Yeah, so 2O non-compliant balloon. Because the way the lesion looks like, either we can take a 2O cutting balloon versus a 2O non-compliant balloon. We don't want to use a compliant 2O balloon because the way the lesion looks like, many a times we under-prep the lesion, and then when you put either 2O stents or a drug-eluting balloon, the chance of patient coming back is high if you don't prep the lesion well, especially the small vessel. So that's the first message I want to give. I mean, even if you want to put a stent here, we want to prep it well, possibly do an IVUS, be happy with our dilatation, and then we go ahead either implanting a stent or a drug-eluting balloon. So in the meantime, while I'm doing the case, perhaps you can discuss small vessel stenting versus small vessel DEB.
So what is it going inside now?
It's a 2O15 non-compliant balloon, and you see I'm struggling because my guide backs way.
So while you're focusing it, maybe I will turn the attention to our panelist, Dr. Jane. Dr. Jane, any comments so far about this case? So far, so good. Xiong Xiong? There's always opinion.
Wherever it is gone,
Good opinion.
Okay, so from angio, it looks small vessel, but if you see at the bifurcation, just at the proximal end of where this balloon is, it looks like it is possibly at least a 2.5 vessel. So I would really consider using an IVUS to really assess the size of the vessel properly. I mean, likewise, the LAD, I think sometimes when you look at what you call small vessel disease, it's actually just very diffuse disease, top to bottom.
Yep, agreed. I think we heard that from Dr. Colombo multiple times. Small vessel disease doesn't always have to be small. You know, have to be careful with those.
But from the very beginning, just because it's a PCI patient, but I don't know whether Ong and also our other panelists will agree with that one, that the small vessel disease, I agreed. But you have diagonal, you have LAD in the proximal and the distal segment also, but its mid segment is quite healthy, and you have also PLD, and it's sort of, and also CTO lesion of LCX with some OMs there. So the first thing for the even for the juniors and even for those who are coming in the intervention world, the first thing may be asked that whether you need a heart team discussion for this one or not. Because this is a very basic thing to do, to think of it. To do the small PCI, nowadays is a small PCI spring, something like this. So 2 millimeter stands are available, so everybody can do that one. But whether it needs a heart team discussion or not,
Sorry, just comment on it. The guide is not coaxial, so maybe you can go to RAO.
The guideline or something, or something like this.
RAO there?
No, I think you have to engage the guide more coaxial in order to push the balloon. Try that one first.
Cranium. Hello, cranium.
Do you need a heart team discussion?
Check.
I think it's a very valid point. I mean, triple vessel disease is a young adult. It's a very, very fair comment.
Check. Yeah.
Yes.
Yeah, I think it's 2, 4. Which area? 6, 8, 9, 10, 11, 12. Down. धीरे थोड़ा सा. That's too far. थोड़ा सा 6, बस. Down.
Now, whatever, but now this is small vessel disease, Dr. Kumar, whether you are planning, it's a NC balloon you have
we couldn't actually cross with the NC balloon, so I actually used a compliant balloon, though I would have liked to use an NC balloon. Now I will actually do an IVUS. Compliant 2O balloon. And we will try to see on IVUS how it looks like. My guess is it would not be more than 2.0. Let's see, 2.25. Maybe I'll give some nitro before I do an IVUS in this case.
Hey.
Yeah. Restrict kar.
Sister, just
So my
pull this
guide keeps backing actually. Ele ho jao.
ये अंदर जो
Can you maybe just comment on the choice of guiding catheter and your approach? I obviously see that you are Jacqueline's right.
Yeah, I mean, retrospectively, I should have gone with an AL1.
Is that your standard practice for RCA?
If it is a CTO, we take an AL1, and we didn't expect it to be so difficult, this one. Only when we started doing the case, we realized that while wiring, I realized it's quite nasty lesion out there, especially the bend and some calcium there. I'm not sure whether my IVUS would cross after a pre-dilatation, but let me at least get some image there, and then we will take a call what is to be done.
Hello.
Hello. Hadia, can you show IVUS?
So this is a volcano IVUS system.
So I'm able to take my...
Yep, we can see your IVUS.
Yeah. So let me do a manual pullback to save the time. I'm in the branch, and it is hugging my catheter, which looks like a 1.5 to 2 mm artery. And when I pull it back, it looks like almost a 2.5 artery. And here there is some positive remodeling, and it looks like almost a 4 vessel at one point. So somebody in the panel, they just said that the vessel can be bigger than what it looks on angio. But you know what? I pulled it back to the main artery, and here you see it's again 2O. I'm into the right coronary now. So the right coronary is around 3 mm, 2.5 to 3 mm. Okay.
Anyone like to comment on the IVUS finding?
Can you run the IVUS again from the beginning?
Dr. Reddy, any comment on the IVUS finding?
In IVUS, it shows that the plaque is extending from the distal coronary artery beyond the bifurcation. Not only confined to the PLV. Very significant lesion.
Yeah. So the comment was that there's a lot of plaque. So, Dr. Kumar, now you have the IVUS information. What's your strategy? Can you share with us?
So what
Maybe
is...
you can just show us the angiogram after you've done the
let me take one angiogram pic because after the 2O balloon, and then I think we'll discuss on this. Though I don't want to take too many pictures. Okay, so if you remember the IVUS pullback, I had actually gone with my IVUS way distal, at which the size of the vessel was around 1.5 to 2. At the site of the lesion where you, on the angiogram where you see some dissection there is a positive remodeling, and the vessel size almost looks like a 3.5 there. Obviously we will, it will fool us if we don't go for the proximal reference point. And before the early bifurcation, the vessel size was again 2O. This is the point you can see on the IVUS. This is the place where it is again 2O, 2.25. So the distal landing zone is around 2O. The proximal is around 2.25. And at the site of the lesion with positive remodeling, if you actually calculate the size of the vessel, it's 3 to 3.5. I would still choose a stent here, a small stent versus a drug-eluting balloon, because the way the lesion looks, it looks ugly. There is a dissection there. And I would go with a 2 mm stent, the onyx stent, and post-dilated with a 2.5 or 2.25 proximally. Simply because the landing zone is 2O, the proximal is also 2 to 2.25. Any comments on that? Onyx law.
Okay. Any comment? Jason, what do you think?
Ganesh, Dr. Reddy here.
Yes,
You're
Dr.
going to put a stent across the PTA?
Across the, if you call that as a second one as a...
This is in IVUS extending from the distal.
Yes, yes. I think we will have to put it just before the PD and not across the PD, just before the PD. The second PD, if you call that as PD.
Not across the bifurcation, right?
You would call the across the bifurcation?
Jason, any comments? 2 stents, or would you do it differently?
30.
We'll place it after. We'll place it after the bifurcation. Here, no. We'll not place it because here the artery size will be
right? That's
24,
26.
26 is.
You better go small first in terms of sizing to the distal reference, the distal vessel, and then of course you can go bigger. But if you choose the oversized stent, obviously there's always distal stent extraction that you need to worry about.
Yeah, Dr. Ganesh, now you have now just coming to a position that where there is a great debate that whether you will go for a drug-coated balloon or whether you go for a stent. You have some issues of dissection there, possibly a focal dissection, or seems like it's a focal dissection, it's not a linear dissection or something. And your distal reference diameter looks like 2 millimeters and stenosis, and the proximal part is 2.25, according to so far the IVUS picture.
Yes.
So according to the distal reference diameter, it's better to put the stent according to the distal reference diameter rather than the proximal reference diameter, right?
Yep.
So, or you are going for the, already you are putting the stent.
Already putting a stent. Irfan, can you tell them about the data between the DB versus...
Recently there was a trial published, the basket small trial, which compared the effects of drug-coated balloon versus the drug-eluting balloons in lesions which were more than 2.5 mm, and according to them the 1 year data between the drug-coated balloon and drug-eluting balloon was actually the results were approximately the same. But there are a few caveats associated with that study, in which first thing is that in all of the lesions which were randomized, there was good lesion preparation. That in those,
what is the size of the stent that you're putting in?
we are putting a Resolute Onyx stent.
What's the length and the size?
It's a
of the
2 by 26 mm stent.
Dr. Kumar, what's
2 into 26 Onyx.
Sorry?
226 Onyx.
226. Okay.
Go. Elio, रुको. Check करो.
I think we'll do on cranial, a bit cranial, yeah.
Check. Go.
That's okay. 1, 2, 3, 4,
6, 8.
5, 6.
I have lost the volume actually. Hello?
6, 7, 8, 9, 10, 12. 12.
So we deployed at 12 atmospheres. Down.
Can you hear us? Actually, I cannot hear anything.
Down. Let's see how it looks on a stent boost. Okay. The volume is not, I can't hear anything from there. Bhatia? वो स्टैंड बूस्ट दिखाने बोलो उनको भाटिया स्टैंड बूस्ट दिखाओ
Ganesh, how many seconds the stent was deployed? I think it's a longer stent.
Yeah, we deployed almost for
38
seconds.
Sensation will be the better, I think.
38 seconds.
Or going the second time also it's better because it will give the good opposition when you keep at least more than 20 seconds.
Yeah, we did for 38 seconds.
In a longer stent.
So we will post-dilate the proximal portion of the stent.
That looks quite nice.
Yeah, it looks good. And generally, our experience, I'm sure many of you would have the same experience, where Onyx is quite safe for the side branch, even the small side branches, purely because of the design.
Dr. Kumar, we just wonder if you can give us another view. the PDA looks like it's sort of abruptly closed off very distally.
The PDA is closed off.
Dr. Kumar, can you have it? Can you take a picture of the epicranial or something to see the PDA properly? Because
I will give a little bit of.
Here that the PDA distal part of the PDA has got no flow.
Okay, we'll do that. Let me post dilate because I want to take limited pictures, keeping the creatinine in mind. So my balloon is in, so I'll just balloon it, give some nitro, and then I'll give the picture. Ready, impression.
That's great, thank you. Of course, that's right. The Onyx 2.0 stent is a very versatile stent. So this one will allow you to grow the stent
10, 12, 14,
14,
16, 16, no.
Yeah.
Stent boost.
So John, you asked for IVUS, and did IVUS change your management plan?
Go.
2, 4, 6, 8, 10, 12, 14, 16.
Bus. So we post dilated with a 2.25 non-compliant balloon, nitro. Paleocranial.
Okay.
अच्छा पिक्चर है इनको थोड़ा कोएक्शियल करके देखो अच्छा ओके अच्छा पिक्चर है थोड़ा पैन करना they want to see the first PD, the large PD. Okay. There's some slow flow. Show me the first picture of the RCA.
In the first picture, probably it was like that only.
Show me the first picture of the RCA. Before the stand. Before the stand. Yeah, before the stand. Before everything, the diagnostic. बंद हो गया स्टेज एडजस्ट में. Yeah, I agree with you. There is an abrupt cutoff of the distal PD.
Next. Yeah.
Why do you think that has happened? Last picture then.
I think we have to take another wire.
Give me another wire.
Yeah. See on.
So I'm going to put another wire into the Xion.
The question is, how did that get occluded? Because
we don't know.
Doing the PL branch.
Yeah, we don't know. Either some thrombus must have gone down.
And ECG, there is some ST elevation in the inferior leaves.
Yeah, there is, and I see some bradyarrhythmias there.
Your anticoagulation strategy for this patient, I presume the ACT been monitored?
We didn't do the ACT now, but in the beginning the ACT was more than 400. That was around 20 minutes back. We can do one more ACT, but we gave 10,000 heparin.
It's a bit bradycardic and BP a bit low now. We need some atropine.
1.5 balloon.
चलो एक atropine दो थोड़ा सा.
Yeah,
1.5 atropine दो.
ये
atropine 0.6 atropine.
अपना
1.5 balloon दो.
Sometimes we know that in light case, because of the satellite patient, the procedure might be a bit longer than we expect, and the anticoagulation side sometimes popping up repeatedly.
3,000. We just gave 3,000 heparin to the patient around 10 minutes back. We're yet to repeat the ACT, but after restoring this vessel, we'll do an ACT on him. Yeah, 2468.
2468 10
down. Check them. Ready. So there we have the flow is restored.
Okay, welcome back.
So let's check an ACT, and you see there is some slow flow even in the area below the stand. वापस दो इधर इन दो 2000 का
Is there any distal stent side? There is any dissection, anything there, or there is no flow in the distal to the stent?
In the beginning there was a good flow.
What do you want, sir?
वापस balloon डालो 1.5 का
1.5 का balloon.
5000
Give me that.
Dr. Kumar, I'll let you focus on your case. You know, we'll have some discussion among the panelists. Just reminding you that, you know, we still roughly have about 5 minutes of SI transmission. But we can see that you already opened up the, you know, subtotal occluded RCA in the PLV. You have very clearly, very slickly demonstrated how you rescue back that PDA. You know, we're seeing a lot of things. So we're just going to let you focus on tidying up that PLV branch for the time being. Maybe we could just discuss the case separately up here. So you just focus on what you want to do.
2468.
No.
Dr. Praveen, in this particular patient, in your practice, would you have tackled the RCA or would you have, you know, maybe tackled the LAD first? I think it's academic because I think the plan was to do both vessels, but would you have started to write it?
So in this case, whether to tackle the left side first is just an operator's discretion because the anterior MA was more than 2 months back. So, of course, tackling the RCA just gives it some stability to the patient and, of course, confidence to the operator to tap to the left later. Tackling first is a good suggestion.
Antonio Colombo, you know, when we see these problems, what we do, we take a monorail balloon, we break the balloon, we make some holes in the balloon, and then we go down with the broken balloon distally, we inject some dye. If the dye hangs there, it means that it is a microvessel problem, and then we use the same balloon to inject nitride or adenosine. Otherwise, is a dissection, but here looks like a microvessel problem. So maybe just go with a broken balloon and inject nitride or adenosine, super selective. Usually helps. The Corandil, whatever.
So some light advice here. So maybe, you know, put a balloon with some nitrate and then inject by a broken balloon into distal vessel.
I think microcatheter would help as well.
Microcatheter दो, ये लो, थ्रोम्बस्टर लो, ये वाला वायर निकाल देता हूँ, हाँ?
No, yeah, you remove that.
Thrombustor, 5 French thrombustor. So I'm actually going to put a 6 French thrombustor and give some medication lower down into the vessel. I still believe all these things happened after the post-dilatation.
Fluid.
But you still have quite a bit of ST elevation as well.
No, it doesn't seem like that only just a case of just dissection or something. I think the plaque burden is also too much there because otherwise why the PDA distally will be occluded because of it has been because of the plaque shifting, nothing else.
We have seen sometimes in young patients when you do an aggressive...
He didn't even touch the PDA.
Yeah, we didn't touch the PDA.
Huh? Yeah, that will be required for delivery.
So the STs are now settling down. Nikalo it. You want to move this? Okay, give some
Nicoran.
truck. Give Nicoran. So my my thrombustor aspiration device is across the stand, and I'm going to give some Nicorandil or adenosine, whatever they give me quickly. Yeah, whatever. There is a good backflow on the. There we go. There's a good backflow on the aspiration device. So that's a good sign.
Nitro%. Plus.
Dr. Colombo was
This
asking.
is adenosine.
This is nitroprusside.
Nicoran.
It's come back to sinus rhythm and the STs have settled, so I don't think I'm going to do too much now on this.
Yep. Heart rate has recovered.
Picture. देखो इसको निकाल के देते हैं पिक्चर. इसको निकाल के दो.
Sometimes mixing a bit of contrast with the nitroprusside
Sister,
also gives us some information.
Okay. Bubble not there. Okay, ready?
Yeah.
So I
Yeah,
think
that's okay.
we should leave it at this and go to the LED now. The STs have settled fully. There is a nitroprusside effect on the blood pressure. I would not like to go in with an IVUS. Perhaps after finishing the LED, I'll come back and look at this. Fluid though.
PB 3.5. Right.
Yeah.
Okay. Then maybe give us
because
another picture.
Even if
Last picture.
we have to post dilate with a 2.5 balloon, the way post dilatation, the way we had slow flow, I perhaps won't do a further post dilatation in this case. Fluid. The STs have settled completely.
My feeling is that the patient is not so stable at the moment. I think we should do the LED another day rather than to proceed to do the LED at this stage, I think.
Yes, that's a good idea.
I think angiographically you probably have good outcome of the RCA. Patient become unwell. We could always come back another day when the patient is more stable.
So
and as I said, you were planning to optimize the RCA stent further, but considering all things considered, you probably want to stage that at the time when you're doing the LED, right?
So can somebody throw some light?
Do you have the final picture without the wire?
No, without the wire I didn't take it because of the. I thought this is good enough. Why, you were suspecting a flap?
No, because the wire was quite far down, so
we're just wondering if, in case there's a dissection with a flap, or where maybe there's some, maybe you can share the final picture with.
Okay.
Without the wire, yeah.
So I'll have to take the guiding back. Give me the guiding back. I pulled my guiding out. I went by the ST resolution back with good
diagnostic.
sinus rhythm. I can take a diagnostic and give it to you. Give me a diagnostic, JR. We are not in a hurry to do the LED, so let's be on the RCA and. ECG दिखाओ एक बार.
Did the patient complain of any chest pain or patient under GA?
No, he's awake. He's not complaining.
The ECG looks a lot better now.
Yeah, ECG is settled.
I think it's always a good habit to do a final picture with the wire removed, because in that case, if there's a wire tip perforation, you may be able to detect it, or there's a dissection. That dissection may be covered by the wire. So
there is a nice blush and.
Not much better.
Yeah.
This looks really nice.
Guiding the left.
Yeah.
I think with the blood pressure coming back above 100, and we have decided to go with the left and finish the left, and obviously today we will not do the CTO.
Yeah, the PDA field got cut off though at the end part. It's not fully the last segment of the
Yeah,
PDA.
maybe the last centimeter of the PD.
That's probably a small territory. And now
Yeah, of course, yeah.
Dr. Kumar, I think we will let you, one day we actually can, summarize your case. I mean, it's a great case. You demonstrated a small vessel disease, obviously a tough small vessel disease, and tougher than a lot of us would expect. And there were a bit of complications, but it was a great save, and we had some really good comments from the panelists and also from Colombo early on, some of the suggestions would you want to take the opportunity just to summarize your case and for our audience?
So here is a young man with a small vessel disease, and small vessel disease is very challenging, in my opinion, to do the PCI. At times, we need to do a limited job in a small vessel PCI. Sometimes we need to base our judgment on imaging, or sometimes a functional study like an IFR or an FFR. Actually, once we fixed this right coronary artery, I would actually go to the LAD, open the mid-LAD block, and perhaps do just a focal stenting there and leave the entire distal LAD as it is. I would not put any stents or any drug-eluting balloons in the entire mid and distal LAD beyond the critical lesion. The diagonal, I would do an FFR. It's quite a big diagonal, and there's a high likely that it will be ischemic. I would use a drug-eluting balloon there, a 2O drug-eluting balloon there, but it looks too small. I will come on another day and do a circumflex and try to do a complete revasc on him, keeping his age in mind. So this is the summary of my case. Anything, can somebody tell me how they would approach on this LAD?
You are just going to touch only the mid LAD?
Yes, just the mid LAD.
You will leave the distal LAD alone, or just you will do something, some manipulation there?
We will leave the distal LAD as it is.
Kumar, are you going to do anything about distal LAD? Because
No. We're going to leave it.
Okay.
Yeah.
Okay. That's
Yeah.
great.
Yeah. What is the
What
opinion
about
there?
panelists? I mean, what's the comment about the LAD?
I think distal LAD should be left because even if you put a stent in the near future, if you want to undergo for a bypass or whatever it is, you're not having any place to graft that area. And do the segment which is mid part, and do the IVAS, see the extent of the flap. And leaving the distal LAD, I think it will be better, because too much diffuse disease quite a significantly extending.
I have just one more question. Interesting. Dr. Kumar, you are just you are going to do the PCI of LAD now?
Yes. The patient is well settled. We hardly
Dr.
use.
Kumar?
Yes, we are going to do the LAD now. And we will stage the CTO of the circumflex at a later
It will
date.
take you a bit longer, but
Actually, when I ventured out,
I want to ask, because to my Singapore and the Indian friends, that how frequently you are using the drug-coated balloon?
we use it a lot.
This bird.
Like 30-40% of the cases we involve DED, and we have very good results from that. And recently, we also we have the usual B Brown Boston type of balloon, but recently we also start trying using the sirolimus coated balloon as well.
So you have a special affinity for the drugs that are coated. Which drug you are using?
We have both
like
the
the DED or the SCB or the
PA
we have Aaron, what's your thought? I mean, would you, in your center, would you have carry on with the LAD, or you would maybe stage it? I mean, I'm just slightly concerned that previously just the diagnostic angiogram pushed him into renal failure. And this case been going on a bit, and you have transient hypotension.
Just a second,
risk is probably a little bit higher.
Yeah, I would stage this just probably together with the just do the LAD another day, and together with the CERC maybe.
Sometimes we have seen when you have an unexplained no flow the way we had, when you're doing the other vessel, there also we end up getting a no flow situation, simply because these plaques are very vulnerable. And when you blow open a stent, especially when you post dilate them, you end up getting slow flow or no flow. Any thoughts on that?
What do you think, Donnie? What's your take on that?
Yeah, I think with Aaron. I mean, the patient has suffered some acute thrombosis in the right side. Means that the patient got high thrombotic state right now. So it means that if there's anything happen, so let's say some minor dissection, it can create some thrombosis in the left side. So for me, I agree with Aaron. Again, I will postpone the PCI and do it another day or another 2 days after this.
Okay.
Same practice in Malaysia, Ashby?
I'm in a public hospital. The more patients I can cancel, I'm more happy. I mean, I'm just joking, but I would actually, defer the patient maybe for another setting. But if you're worried of slow flow, IVUS will actually help. You can look at the plaque and see whether it's attenuated plaque and so on, so higher chance of slow flow and things like that. Because you already got an IVUS there. Thank you.
Do you remember the
consensus here among the panelists that the feeling is we will have deferred it, but we're obviously interested to see how you will carry out the case. But just reminding that the satellite will probably cut out in about less than 5 minutes.
So if I have 5 minutes, I will at least do an IVUS and give the.
I'm just
2, 4, 6, 8, 10, 12, 14, down. Nitro.
What is the size of balloon, Kumar?
2O. So 2O compliant balloon.
I'll give you a non-scientific explanation on why you might want to carry on. It depends on whether the patient has to come back and pay for the procedure. Because you come here once, you pay for the lab once, right? And you come back again, you pay for the lab the second time. So sometimes you have to take into the financial limitation consideration as well. But since with just the RCA, the patient's blood pressure drop, in this case, you probably want to stand by a lot of your other medicine. Because once you blow it, again, the blood goes down, no reflow, and you're going to end up with the same thing.
So I cannot advance my, okay, I could advance my IVUS. So can you go to the IVUS live?
Yeah, we can see your IVUS.
Okay, I'm doing your manual pullback to save time. So it's really very small distal LAD. It's hardly a millimeter and a half. Some plaque you can see at an area where there is the last diagonal. The concentric plaque here, around 2.5 vessel at the site of, this is the site of the lesion. And there is again a positive remodeling, similar to the way we saw in the PLV, where the vessel size was 2.0 and the positive remodeling made the vessel almost look like a 3.5. Here too, if you see, there is a positive remodeling from almost 6 o'clock to 12 o'clock with a huge plaque burden. And these are the typical cases where you have a positive remodeling.
At the moment it's not moving, right?
Yeah, I'm not moving. I just stopped it for discussion. I'm just pulling back the IVUS now. The artery size is quite big below the major diagonal. This is the proximal LAD, which is around 3.5. The whole thing is layered with plaque. Left main looks all right. Any comments?
You have plaque extending very distally. Where are you going to put the distal stent? Where are you going to land?
No, we are not going to put a distal stent. We are going to put the stent. You see a small dike is arising from the critical lesion, just above the critical lesion. Are you on the angiogram? Are you with the same page with me? Let me take a picture. Show me a picture with a nitro. Give a nitro and we take a picture. Let's discuss from where to where we put the stent.
Just before the distal diagonal?
No. The last diagonal is there much before that.
Where the co-registration of IVUS will be very useful to correlate where your plaque burdens are with the angiogram. But Dr. Kumar, just maybe in the interest of time, can you share with us what's your plan here?
See, again, I'm expecting a no flow here with a small balloon. Go. See there is no flow.
I think again you have that issue, the same issue there. So you have to go faster and do whatever you want to do.
2.5.
Yeah, 2.5.
2.5.
2.25 stand.
32 from here.
Yeah, 32.
32, yeah, 34. 2.25, 34.
This is what we had predicted actually. You do a small balloon and you will have a no flow. And this is a 2 months post MI. The same mechanism we had a no flow on the right side is a similar mechanism here. Positive remodeling, lot of plaque burden, lot of vulnerable area. You just touch with a balloon, it breaks into fragments and you get no flow. Despite high dose statin for 2 months.
In this case, I'll probably use a different strategy. I'll probably balloon it first, so that I can see the distal vessel better. See if the small balloon may have detected more distally, so may not be, may need the longer stent to cover the dissection.
In this case, glycoprotein 2B inhibitor is going to help anything in giving a slow flow, a lot of plaque burden, distal microtumulation, anything? Kumar? ACE2 inhibitor is going to help anything in this?
ACE inhibitor, I'm not sure. Yeah, little down.
I'm talking about whether it's covering properly or not.
Yeah,
go.
2. Go.
2,
3, 4,
4,
6, 8.
6, 8.
Just under deploy it, it's okay. Don't go beyond 8. 9, 10. He's tolerating it much better than the right coronary artery and occlusion, probably because it's an infarct-related artery. Down.
So this those are not suspended yet.
So do my colleagues in Singapore see such phenomena when you treat small vessels, you start getting no flows like this?
Nitro.
Yeah, Nicoran. Yeah, Nicoran.
Guide in.
Guide in. Yeah. Go.
No.
Go. So I'll be seriously happy with this picture. I'll optimize it after the IVUS, or maybe I will do an OCT now and see for any malposition. Here I would be little concerned about.
So would you consider putting this patient on some 2B3A inhibitors? You have with no referral for the moment twice already in this patient.
I don't expect him to have
proximally there is
an event now
lesion which was missed, looks like proximal stent.
Come again? Yeah, proximal stent, we have to look what's happening there.
Proximal to the stent.
You need to post-dilate the lesion, proximally, the stented segment.
Yeah, give me the IVUS. Or OCT, eh? Give me an OCT.
I think probably you need one more stent at the proximal. Short one, and then post-dilate the distal stent which is not fully deployed.
And maybe add in some 2B3A inhibitors would be a good idea.
Yeah, we'll do an OCT and then we'll take a call what to do, because these cases, if you remember, there were areas where the size of the vessel was almost 3.5, and there are areas where it is 2, and there are areas where it is 2.25.
Dr. Kumar, before putting some imaging modalities, first you need to treat the proximal part, because it has a plaque burden in the proximal part of the stented segment.
Yeah,
and also in the distal part there is the under-expanded stent.
Yes, so...
and also proximal to the standard segment, you may need another stent.
3 oka stent.
Dr. Kumar, I think we'll be losing the satellite connections very soon. Okay, so once again, thank you very much for sharing this very interesting case. You know, obviously, a lot of learning points with the complications associated with no reflow. Thank you for your team. I think, you know, we probably will wrap it up here. So thank you once again from India for this live transmission. We will thank Medtronic for sponsoring this session. My co-chair, Dr. Rahman Khan, and all my learned colleagues as panelists for the excellent comments. So the session will end. I think there are other dinner symposium, and otherwise see some of you nice and early tomorrow. Thank you very much.
Thank you.
Thank you very much from Mumbai.